So hello and welcome everyone to this advanced coding webinar. Welcome back if you attended the MedDRA Coding Basics webinar last week already. And nice to meet you all to go through some additional, more advanced aspects, examples, and exercises on how to perform MedDRA coding. I'm Caroline Wilson and will be your instructor today. And I'm supported by my colleague Leander Mold, who was speaking to you before. So together we will take you through this webinar, which will last for about 2 hours. We would like to make this webinar interactive. Leander mentioned this already, so please submit your questions or send us your comments through the question panel. And I will allow as much time as possible for questions during the course and also at the end of the presentation. But just to let you know, please do not raise specific coding questions, specific verbatim terms that you would like to know how this should be coded, because we can't help you with individual verbatim terms, but we can guide you in terms of coding principles, of course. Now let's start with the slides. Most of you will know that ICH adopted the development of MedDRA in the mid of the 1990s and became the owner of the terminology. ICH then on contract appointed the MSSO to take care of the maintenance and further development of the terminology based on user feedback, to provide and organize corresponding training as the one that we have today, and to administer the MedDRA licenses. And all these MSSO activities are overseen by the so-called ICH MedDRA Steering Committee, with members from regulators from all over the world and also industry association, and the WHO as an observer as well. ICH is not only the owner of MedDRA itself, but also owns today's training material. It is protected worldwide. You may use the slides with the exception of the MedDRA and ICH logos, but will have to clearly indicate that ICH owns the copyright. Also, any adaptations of the slides have to be clearly labeled. The second bullet point on the slide here refers to warranty and liability issues you should be aware of, and the third one is not relevant for today because we will not be using any third-party slides. These are the topics that we will cover today. We will first discuss some more advanced principles that are outlined in the Points to Consider document for MedDRA term selection, which is the coding guidance document provided by ICH. We will then look into the MedDRA concept descriptions and at several advanced coding scenarios. And we will use the Poll Everywhere application in the MedDRA browser to apply some of these advanced concepts from the MedDRA term selection Points to Consider document. Finally, we will go through some tips for coding, what we call the coding pearls, to help you with your coding tasks. And we will conclude with a Q&A session, but as mentioned earlier, you will be able to raise questions throughout the session as well. But again, please understand that it is not in the scope of this training to help you with very specific verbatims that you came across, but rather address the advanced coding principles and related coding scenarios on a more general level. Now let's start. The next two slides explain about the polling. If you would like to join the quizzes and participate in the examples today, there are two ways to do so. So the easiest way is to scan this QR code with your smartphone or tablet. We'll leave it on the screen for a minute. Or you may enter the indicated web address, paulf.com, into the URL bar at the top of your internet browser in your computer, tablet, or cell phone. It will then take you to a log on screen, and you'll be asked for a username. The poll, just to let you know, is completely anonymous, so you don't need to enter your name as username, but please enter my name as the username. It's Carol N. Wills 584 with no spaces. Nothing more needs to be entered, So then just click join. So skip this and click join. And Leander has put these credentials in the chat as well. Now let's see whether the polling tool works today. Here we are. Where are you joining from today? Oh, many people from Europe. I see France, bonjour. I see Turkey, merhaba. South Africa, good morning. Canada, it's very early for you, very early. India, New Zealand, Japan, Russia, lots of people in Europe. Hard to see. Italy, I see. Buongiorno. Dobry dzień to Russia. So we have nearly all continents today. So welcome everybody. I'm sitting in Berlin in Germany and I'm very happy to welcome you all. So let's start. The tool works, obviously. So have you already attended a MedDRA Coding Basics webinar? So obviously most of you did. That's good to see, because today we will just only address the advanced coding principles. The basic principles that are outlined in the MedDRA term selection points to consider document are addressed in the MedDRA Coding Basics webinar. So if you didn't attend it yet, please do so, because the MedDRA structure is explained in more detail there. So I will not go into the details of the MedDRA structure and the basic coding principles today, just the advanced ones. Now let's start with our topic today. So let's look first into the MedDRA term selection points to consider document. So this is the cover page of the current ICH points to consider document for MedDRA term selection for version 28.0. It's only released once a year. It provides guidance and many examples on how to perform accurate and consistent term selection using MedDRA. So this guidance should be the basis for coding decisions of all MedDRA users, thereby promoting, of course, overall coding consistency and also facilitating common understanding when sharing clinical data. So MedDRA allows us to speak with one language when sharing medicinal product safety information between different biopharmaceutical companies, between pharma and CROs, or when talking to regulators. This document was developed and is maintained by an international expert working group appointed by the ICH Management Committee, with members from regulators and industry of the ICH regions, the MSSO, and the Japanese Maintenance Organization, or JMO, and the WHO again as an observer. There is one original and comprehensive version that is available in English, Japanese, Chinese, Korean, Spanish, and Russian. It is updated with each major MedDRA version release. That means beginning of March each year. In addition, there are condensed versions of this original document in other MedDRA languages, except those that I have just mentioned. And you see these languages listed on the slide: Arabic, Brazilian, Portuguese, Czech, Dutch, French, German, Hungarian, Italian, and Portuguese. These condensed versions focus on the general coding principles without going into further details for selected topics. They are not updated with each MedDRA version release, but on an as-needed basis only. The Coding Basics webinar I've mentioned before focuses on the basic principles for term selection that are outlined in the first part of the Points to Consider document. Today we will focus on specific coding topics, more advanced ones that are addressed in the second part of the PTC document. And you see the list of these topics here, like diagnosis and provisional diagnosis with or without signs and symptoms, outcomes, patient outcomes, suicide and health, self-harm, how to handle conflicting, ambiguous, vague information, how to handle combination terms, how to prioritize age versus event specificity or body site versus event specificity, exposures during pregnancy, congenital terms, neoplasms, and the list continues on the next slide, as you can see here. So medication errors, overdose, toxicity, poisoning, drug interaction, no adverse effect, normal terms, how to code medical social history data, off-label use, and product quality issues. So a broad range of topics addressed in the second part of the document. And we will address all of them that are highlighted in yellow, either in our examples or by going into more details in terms of content. Let's first start with some important general principles, just as a summary of what we have addressed last week. So we have already discussed them in more detail there. Coding is done on LLT level, the data entry level, and only current LLTs must be used in ongoing coding. The LLT selected should capture as much information provided by the original verbatim as possible. So that's the principal coding rule, code as reported. So when coding, we should not add or also not subtract relevant medical information. As can be seen in this example, reported is an abscess on the face. This verbatim should not be coded to just abscess, because it is medically relevant to also capture the manifestation site that was reported, because an abscess could be located in the brain, in the lungs, whatever. So we need to capture the manifestation site. That's why it's important to code to LLT facial abscess. So with this, we would capture as much information from the report as we can, not only the condition, the abscess, but also the manifestation site. And always remember to select current LLTs only. The non-current LLTs are still in the terminology for historical purposes to support interpretation of legacy data and also legacy data conversion, but they should not be used for ongoing coding. In some instances, you may consider to select more than one MedDRA term to capture the full information of the verbatim. Let's look at the example on this slide. If you are to code the verbatim metastatic gingival cancer, you may decide to select either LLT gingival cancer or LLT metastatic carcinoma to not duplicate the event. But selection of only one term will lead to loss of information, and you would need rules for the prioritization of the information received to ensure coding consistency. But you may also decide to capture the full information and split code by assigning LLT gingival cancer and LLT metastatic carcinoma. When taking this approach, you would duplicate the event that is the malignant neoplasm information. In the end, you are free to choose either option, what we call lumping or splitting. But make sure to document your rules and to use them consistently. Now let us look at another example for the split coding topic that we just addressed. How would you code left foot and ankle swelling? Would you split this reported event and code to swelling of feet and ankle swelling, or would you lump this information under one of the other LLTs? How would you approach this verbatim? I see you voting already. So let's see what you're going for. Yeah, most of you would split code, and this is completely right. Yeah. So let me close the poll. Here we are. 75% are really looking for split coding or voting for split coding. And this is actually the correct approach. So we would code to swelling of feet and ankle swelling. Why? Because ankle swelling resides under the PT joint swelling. The ankle is considered joint in MedDRA, whereas swelling of feet is grouped under peripheral swelling. So that's why it needs to be split in this instance, this verbatim. Now, next example. How to code pain in hand, severe pain in leg and toe. Would you code pain, musculoskeletal pain? Would you split code pain in hand, pain in leg, and pain in toe? Would you code to pain in extremity? Or would you split code to pain in hand and pain in leg because the toe is part of the leg? What would you do? Most of you would split code again, but some would also consider pain in extremity in this instance. So let me close the poll. Here we are, and see what we have. So we have a different scenario because all reported events can be coded to LLTs that are grouped under one single PT. And this PT is named pain in extremity. So in such situations, you would select the LLT that is identical to the PT name. And again, you can see that checking the hierarchy is important because pain in hand, pain in leg, and pain in toe all are grouped under the PT pain in extremity. As indicated before when showing the splitting examples, checking the hierarchy is an important general principle for term selection. Before making a coding decision, in more complex cases, it is always advisable to check the MedDRA hierarchy to reassure yourself that you are on the right track, that the selected LLT is medically correctly represented in the MedDRA hierarchy. As an example, a non-infectious condition should not be represented in SOC infections, or a condition which was acquired later in life should not be coded to a term in SOC congenital. So the slide provides an example. If you are to code the verbatim feeling completely drained or low energy, you won't find any exact match in MedDRA. You may then consider to assign LLT worn out, but may be unsure whether this is appropriate. But when checking the corresponding PT fatigue and the LLT siblings underneath, like for instance LLT exhaustion, LLT washed out, and LLT tiredness, you will feel much more comfortable with your coding decision. When not checking the hierarchy, you may even end up with a completely incorrect code assignment. If a patient suffers a ventricle rupture due to a pre-existing hydrocephalus, the selected MedDRA term should, of course, reside under SOC nervous system disorders. The correct term would be cerebral ventricular rupture. Same PT. When searching for ventricle rupture and not checking the hierarchy, one may assign the LLT ventricle rupture. It seems to be a perfect match. But this LLT and PT is grouped under HLT myocardial disorders, NEC, and resides in SOC cardiac. So this is really a real-life example that I came across when doing spot checks of code assignments when working in pharma. So always check the hierarchy in more complex cases. Another topic that I would like to highlight today are the concept descriptions. These are descriptions on how a medical concept is interpreted, used, and classified within MedDRA. They do not represent medical definitions, but they may be helpful for you when searching for suitable LLTs. The purpose of the concept descriptions is to support accurate and consistent use of MedDRA in coding and in data retrieval. They intend to help to overcome differences in the use of medical terms worldwide. You will find the concept descriptions in Appendix B of the MedDRA Introductory Guide, but you can also access them in the MSSO MedDRA browsers. If you click on the corresponding icon of the MedDRA browser, this window will open. You can then select the appropriate section to view, because all the concept descriptions are sorted in alphabetical order. So let me now show you where to find these concept descriptions. Here is the MedDRA browser. It's already open. It's the legacy one, the old one, not the new one that we have released last year. So here is the icon MedDRA concept descriptions. And if I click on it, you see exactly the window that I've just shown on the slide. And you see the alphabetical order. So let's look for, in C, cancer carcinoma. You see that cancer and carcinoma are considered synonyms in MedDRA. Let's look for other terms like dose, for instance. What is a dose? A quantity to be administered at one time, such as a specified amount of medication, whereas dosage is the determination and regulation of the size, so dose, the frequency and number of doses, so the duration of treatment, so much wider term, more broad term. And let's look for another option that we have, like overdose. So overdose, for the purposes of the term selection and analysis of MedDRA coded data, overdose is more than the maximum recommended dose in quantity and or concentration. In other words, an excessive dose. And what about underdose? Here we have some product quality issues. Product quality issues are abnormalities that may be introduced during the manufacturing, labeling, packaging, shipping, handling, or storage of the products. And here you have some product odor abnormal, so product taste abnormal, solubility, so some terms that relate to the quality of products. Sometimes they are really very specific. It's worthwhile to look into these concept description. Underdose, again, for the purposes of term selection and analysis of MedDRA coded data, underdose is the administration of less than the minimum recommended dose, again in quantity and or concentration, similar to what we saw for the concept description of overdose. So this is what I wanted to show you. So it's really, if you're not familiar with the MedDRA terms, especially when it comes to quality terms, product quality terms, and also medication errors, medication use issues, then they are really helpful. Do we have questions so far, Leander?
We had a question just to help clarify the split coding, because we had with the pain in the hand and the leg and in the toe.
Yeah. So whenever, so we will readdress it in some examples that we will look into just in a few minutes, but you have to split code when a verbatim term relates to more than one medical concept, and when you don't find a combination term in MedDRA. So then you have to split code, and you can put everything or code to one term that is the LLT identical to the PT name when the LLTs that are associated with a certain condition, like we saw with the pain in toe, pain in leg, and pain in arm, for instance, then you can just select LLT and PT pain in extremity. So that's why it's always important to check the hierarchy, because otherwise you would duplicate the event. You would have three, if you would code everything, pain in toe, pain in leg, pain in arm, then you would duplicate the event, pain in extremity. Hope this answered your question.
Thanks, Caroline. And then we just had one come in saying, do LLTs must be coded to their SOCs, to their SOCs?
Well, they are hard-coded in MedDRA itself. Yeah, so we have, this is something that I've addressed in the basic course. So we have the hierarchy, we have multi-axiality in MedDRA. Sometimes you have terms that are associated with different system organ classes. So this is all hard-coded in MedDRA. So when coding, you do not have to think about SOC assignments because it's hard-coded in MedDRA. We always have a primary SOC assignment that is defined by MedDRA, and this is the system organ class you would code to. And the secondary linkages are only considered when it comes to data analysis. It's not something you have to care about as a coder. Anything else?
Thanks, Caroline. No other questions at this time.
Okay. So then let's continue and now address some of the specific advanced principles that are addressed in the PTC term selection guidance document. The first advanced principle in the document is the coding of confirmed or provisional diagnosis with or without signs and symptoms. If we have a single diagnosis without signs and symptoms, which is confirmed, we will only code the diagnosis because this is the only information that we have. Like in this example, myocardial infarction can only be coded to myocardial infarction. If a provisional diagnosis is reported without signs and symptoms, we would take this suspect diagnosis as if it was confirmed and code it accordingly. In parallel, of course, we would ask the reporter for more information whether it was meanwhile confirmed. And the same approach would be taken if you have multiple confirmed or provisional diagnoses without reported signs and symptoms. Next, we have a different coding scenario where either a confirmed or a provisional diagnosis is reported with clinical signs and symptoms. For such coding scenarios, the PTC document provides a preferred and an alternative solution. For a definite diagnosis with signs and symptoms, the preferred option is to only extract and code the diagnosis. And here we have an example. Anaphylactic reaction with rash, dyspnea, hypotension, and laryngospasm, you would code to anaphylactic reaction only because all these signs and symptoms are characteristic for an anaphylactic reaction. And in the case of signs and symptoms that are reported with one suspected diagnosis, all signs and symptoms and the provisional diagnosis are to be coded. In case signs and symptoms are reported with several suspected diagnoses, all signs and symptoms and all provisional diagnoses are to be coded based on the preferred option. Alternatively, signs and symptoms can be coded in addition to the diagnosis when having a confirmed diagnosis. So then you would split code and not just code anaphylactic reaction, but each of the reported signs and symptoms. When you have a provisional diagnosis only, then you would only code the signs and symptoms because the provisional diagnosis may change. That would be the alternative option. So if you have a possible myocardial infarction with chest pain, dyspnea, and diaphoresis, you would ignore this suspect diagnosis and just code the signs and symptoms. So both options, the preferred one and the alternative option, can be selected. But the approach chosen has to be applied, first of all, consistently, and also this needs to be documented in the coding conventions, and your coders need to be trained accordingly in order to ensure coding consistency. So when taking the preferred option, this is more simple, would lead to a leaner database, to less noise in your database. When taking the alternative approach, when it comes to definite diagnosis, for instance, you would be on the safe side. You would capture everything, not omit any reported information, but data retrieval and analysis may be more complex then. However, one cautionary remark when taking the preferred approach only. So the PTC document clearly states that signs and symptoms that are not associated with the diagnosis, that are not typical for the diagnosis, will always have to be extracted and coded separately. And honestly, even with sound medical background, this is sometimes hard to decide. Clinical signs and symptoms are often not pathognomonic, so meaning that they do not point at only one diagnosis, but could relate to many. So the example that is provided in the points to consider document is quite straightforward, easy. Myocardial infarction, chest pain, dyspnea, diaphoresis, ECG changes, and jaundice. Of course, the jaundice is not typical for a myocardial infarction, so this is easy. But I can tell sometimes it's really not easy to decide what can be considered characteristic for a given diagnosis. Let's have a look at another example for this topic now. Here we have two suspect diagnoses plus related signs and symptoms. So which LLT would you select based on what you've just heard? Applying the preferred approach. We always apply the preferred approaches when having our trainings. So preferred approach. How would you approach this verbatim? You can select more than one term here. And it's really not necessary to search in your browser. Just apply the principles we have just addressed and select the most appropriate LLTs. Sepsis leading to shock from possible spontaneous bacterial peritonitis or bowel perforation. So you would code the two suspect diagnoses, of course, yes, spontaneous bacterial peritonitis and bowel perforation, and you would code the septic shock. So here we have split of opinion. Some of you would choose or select the combination term, others would split code sepsis and shock. So let me close the poll and let's check your answers. We have to capture both provisional diagnoses. Perfectly right. So that's what we need. And for the provisional diagnosis, the preferred option provided by the PTC document asks us to code the associated symptoms in addition. And here we have split opinions. Some of you would split into sepsis and shock, but the majority prefers to code septic shock, and this is fully correct. We can assign a combination term that captures both the reported sepsis and the shock condition, septic shock. So here we have the solution: septic shock, spontaneous bacterial peritonitis, and bowel perforation. So some of you have preferred to split into sepsis and shock, but the majority prefers to code septic shock. So if the sepsis has a fulminant course and the subsequent septic shock would occur more or less at the same time, you could directly use the combination term, septic shock. Of course, from the data management perspective, if the patient is first diagnosed with a sepsis in the hospital and then develops a shock later on because the antibiotic treatment is not effective, for instance, then you would like to split because the start date of both events will be different. But when splitting, do not split into sepsis and shock. Some of you did, but into sepsis and septic shock to capture the relationship between the shock and the sepsis. So somehow it will depend on the individual case how you would handle this verbatim. Any questions, Leander?
Yes, we've had a few questions. The first question, diagnosis versus symptoms consideration is dependent on the type of reporter. Is that correct? HCP versus consumer?
No, if you have a consumer report, if you have to code what you get, yeah. If it's we come to ambiguous or vaguely reported conditions later on, but otherwise you would code everything that is reported. Of course, when you have a report from an HCP, it will rather be medical language, not difficult to interpret, clearer than when you have a consumer report, because it may be in lay language and may not be so easy to understand, but you would capture everything, irrespective of the fact whether it was reported by HCP or patient or consumer.
Thanks, Caroline. And if we have the same event which occurred in different dates, should we code just one without dates, or should we code several times with its dates in each code?
Yeah. This is really a data management, data entry question. It really depends. If you have two events, like we have with our sepsis and then the following septic shock, if this occurs more or less at the same time point, because it's a fulminant course of this sepsis and leading to shock, then you could summarize it. You would have more or less the same date of the event. But if you first have the sepsis and the shock develops later on, you have a different start date of this condition, then you would split code. But if you split code, then you should not just code sepsis and shock, but code sepsis and septic shock. And this needs to be considered when splitting.
Thanks, Caroline. And how do we know that the LLT that we use is up to date?
So you mean that it's not non-current? We come to this later on. I show you an example later on so that you see how these non-current terms are highlighted in the browser. Just wait a moment. We will get there.
Thanks, Caroline. And just one more.
Yep.
I understand it is hard-coded, but I'm aware in some cases the reporter did not agree and wanted to have the LLT under a different SOC. In this case, it seems they need to code to a term under the same. Sorry, let me read that again for you. I understand it is hard-coded, but I'm aware in some cases the reporter did not agree and wanted to have the LLT under a different SOC. In this case, it seems they need to code to a term under the SOC they believe is correct.
Oh, I wouldn't do so. I would always take the verbatim as the guidance for coding purposes. And you would need to check whether the system organ class preferred by the investigator, for instance, or by a product expert that doesn't like this assignment to a SOC is available. So answer should always be MedDRA was implemented in order to standardize the coding, to ensure that we all speak the same language, and also that data presentation is consistent across all MedDRA users. And that is why one should always follow the MedDRA hierarchy. So no different assignments. If you find that a SOC linkage, for instance, is missing in the hierarchy, then you can submit a change request, but you should not change the SOC assignment or try to find a suboptimal term in a specific SOC because of interference of medical experts. I know that I'm a medic myself. I know that some colleagues with a medical background, they tend to, when they don't have appropriate MedDRA language, that they try to pursue some strange policies in order to get a certain adverse event or even adverse drug reaction under in their view appropriate SOC, but this is not the way we should handle that. So as a coder, you don't have to, if you have the correct LLT that correctly represents your adverse event, the adverse reaction, then you should assign it, irrespective of SOC assignment.
Thanks, Caroline. And there is just one more, and then I'll let you move on because I know you're going to cover various bits.
Yeah.
For multiple coding, should we then ask the site to split the events? So if
Yes.
it's not a definite diagnosis, to report each sign and symptom separately as well as the possible diagnosis?
Yes, depending on your coding conventions, that is what you should do. But it's also dependent on your own data management conventions that you have in your company and your database. So usually you cannot just split one term in separate events in your database. So that's why you have to go back to the investigator in order to ask for splitting a term. Sometimes it's difficult because they do not understand why this should take place. But that's why in investigators training, it's always important to at least provide some term specification instructions to them so that they understand why we query these terms.
Thanks, Caroline. I'll let you carry on with the presentation, and thanks everyone for your questions. It's great to have an interactive audience, an active audience.
Okay, next one. Another frequent problem area is the reporting of conflicting or ambiguous information. And the slide provides two examples from the points to consider document. If no clarification can be obtained, you will have to find an adequate coding solution for such verbatims. So in the first example, the diagnosis hyperkalemia does not match the lab result that rather indicates hypokalemia. The recommended coding approach for such terms is to code to the respective abnormal MedDRA LLTs. Here, serum potassium abnormal. Coding then covers the fact that the lab result is not normal, but doesn't make any assumptions whether it is below or above the normal range. By the way, coders are frequently confronted with numerical values for lab values that need classification, and it is really advisable to add one or two references like the Oxford or Harrison's textbook of medicine to the coding conventions that are to be used as a standard. A different scenario is shown in the second example, where we see an ambiguous abbreviation, GU, that could indicate either genitourinary or gastric ulcer pain. If we cannot obtain clarification from the reporter, the best solution is to code to the underlying basic medical concept, that is pain in this instance. If confronted with abbreviations, check in some references like dictionaries for medical abbreviations in order to find out whether on an international basis, this abbreviation will always mean the same thing, meaning that it is not ambiguous. MedDRA contains abbreviations, but only if they are non-ambiguous. Especially when receiving consumer reports in pharmacovigilance, vague information may be reported and there may be no chance for further clarification. Turned green is a nice example here. Could relate to the skin or tongue of a patient, but also to a drug like a capsule or cream that has changed color. So we do not even know if this is something that affects the patient. That is why we would code similar verbatims to LLT unavailable event. If we knew that there is something wrong with the patient, as shown in the second example, patient had a medical problem of unclear type, we would choose LLT ill-defined disorder. MedDRA includes several LLTs and PTs in SOC general that can be used for such vague scenarios where we know that the patient is affected, but we do not have the information about the specifics of the reaction. And we have PTs there like general symptoms or PT local reaction as well. So next one. Here we have, heard about ambiguous, vague information. So based on what you just have heard, how would you approach this verbatim? Patient had an MI. What would you do with it? Would you go to myocardial infarction, ill-defined disorder, MI, you will find it in the MedDRA, or unavailable event? What would you do? Patient suffered an MI or had an MI. So most of you go for unavailable event, but we have split of opinions here. Let me close it. So let me show you in the browser. So we had a respective question before. Oops. What happened now? No, I see both. That's strange. Something happened. Let me try again. I cannot move it. Oh, I have problems.
Oh, we've got the polling tool across your screen at the moment,
Yes,
Caroline.
yes. That's exactly what happened. I thought that we will. Let me try this one. No, it's always if I try to switch screens, this polling comes up. Whatever I do. Let me try another way. No.
Just bear with us, everyone. We'll just try and work through the getting rid of the polling off the screen at the moment while we switch to the browser.
I do not have any clue why this now happened.
Might be worth just closing down your PowerPoint presentation, Caroline, and reopening it.
Yeah.
If you stop sharing just for a moment.
I'll try. So I will. Okay. So I've now stopped my presentation. Let me log in.
Yeah. Yeah, we can see the browser.
Yeah. So we'll have to reopen my presentation then afterwards. Yeah. So here we are, and we try to find the exact wording that we had in our verbatim MI. And if I click search, you see your search has returned too many results to display, 10,000 something, because the search engine now looks for this string MI, and of course you find many. So you could now say, so I restrict my search to cardiac disorders because I assume it's a myocardial infarction that was reported here. But even then, we have 279 hits, so quite a number. Let's clear the selection and show you how you best can approach it with advanced search in the browser. And here you could say exact match and enter MI, here we are, and search. And here you have the LLT MI, and you see that the LLT is in red lettering and with a red square around it, And if you look into the legends, you will see that this is exactly how the non-current LLTs are highlighted. MI is a non-current term because it's an ambiguous abbreviation. So now let me start my presentation again. And I will have to find where we are. Here we are. So do you see it now?
Yes, I do, Caroline. Yes, I see your presentation.
Yeah. So here is our head MI, and you would now say that this is an unavailable event because it may relate to mitral insufficiency, to mental illness, to even medical investigation or medical inspection, so not even a condition in the patient. And that's why unavailable event would be correct in this instance. Well done. Most of you got it right. Next topic. When coding investigational results, please remember the following. MedDRA includes medical conditions in the relevant system organ classes plus related investigational results like lab results in SOC investigations. Therefore, it is important to make this distinction. It is a fundamental rule in MedDRA that you should not change internally. Remember the basic MedDRA coding rule, code as reported, meaning that if a medical condition is reported or a diagnosis, code as such. And when an investigational result like a lab value or diagnostic finding, imaging finding is reported, select a term from SOC investigations. Never interpret a lab test result as a diagnosis. When receiving precise reports on investigational results, like in the first example, there is no problem. The value is clearly below the reference range and the verbatim can be coded to LLT glucose low. But often, investigational results are reported without units, like in the second example here. We don't know whether this refers to 40 milligrams per deciliter, which would be low, or 40 millimoles per liter, which would be high. Such reports are ambiguous and should be coded to a suitable abnormal LLT if there is no option for further clarification. In order to classify lab values as low or high, not just decreased or increased, again, you will need standard references to decide whether the reported value is clearly below or above the normal range. I mentioned this earlier already. Quite frequently, a diagnosis is reported with the corresponding lab values. In such cases, you are not obliged to capture the diagnosis plus the investigational results as long as these are consistent with the diagnosis. Because when a hyperkalemia is reported with an investigational result that supports the diagnosis, like in this example here, splitting would lead to redundant information. So we would only code to hyperkalemia in this instance. But when would splitting of investigational results become necessary? So let's have a look at the second example that we see on the screen here, where 4 different abnormal liver function test results are reported. Increased alkaline phosphatase, increased SGPT, increased SGOT, and elevated LDH. Remember the fundamental principle, MedDRA coding rule, code as reported. Do not omit parts of the reported events. So do not lump the reported findings under one summary term like liver function tests abnormal, for instance, but split code and code each of the specific reported findings separately. So here we are. Another example for you to try. Testing showed increased serum creatinine and BUN with increased BUN creatinine ratio. How would you approach this verbatim now? Based on what you just heard. Let me check. Exactly. You would split code. You would not assign renal function test NOS abnormal, but you would capture all information in the verbatim. Well done. Here we are. You would split code. Next one. Patient had features of aldosterone excess. Would you code to aldosterone increased, aldosteronism, or blood aldosterone abnormal? So this is more tricky, this example. Let's see what you're going for. Split of opinions. Most of you go for blood aldosterone abnormal or aldosterone increase. Some of you would choose aldosteronism, but it's the minority. So let me close the poll again. Let's look at the verbatim again. What is reported here is not an investigational result. We are not told that the aldosterone was measured and resulted to be excessive. But what is reported is that the patient had signs and symptoms, features of aldosterone excess. So it is a condition in the patient. That's why it's always important to really look at the verbatim. What is reported here? So here, in this instance, we would not code to a lab result because it's a condition in the patient that is reported, but we would code to aldosteronism. So this meant some of you have taken this correct approach here. Any question?
We do have some questions. Just bear with me, Caroline. With only coding unevaluable event or ill-defined disorders, are cases invalid? I mean, we do not have still the minimum criteria to validate adverse events unspecified.
Yeah, but you have a report, so something happened to the patient, but you cannot specify what actually happened. So this would still be depending on the circumstances, you know, it will depend on the case information that you have, but it's still something happened to the patient. Yeah, either it was an investigational result that was abnormal, or otherwise it would not have been reported either by the patient or the consumer or HCP.
Thanks, Caroline. And for the ambiguous terms, if we could understand, for instance, based on the narrative or the medication used, that an ambiguous term is referring to a specific term, could we code to that term we believe is correct based on our own interpretation of the whole data and not only the verbatim?
Yeah, again, this depends on the database. So of course, if you are coding in a case in pharmacovigilance, if you have the full narrative information, then the term extraction must be correct. So you should really extract the relevant information in order to code. If you get something from an investigator that where you know that some additional information is provided in the CRF that is not contained in the verbatim, then it depends on your data management conventions. This needs to be documented in the data management conventions, whether you're, for instance, allowed to add gender information or age information whatsoever. Usually you have a separate database field for it, because if you just do not change anything in the verbatim, then the coding would not match the verbatim. This looks bad.
Thanks, Caroline. And when do we know if it is a definitive or provisional diagnosis?
Based on the verbatim. So when it is suspected or suspected diagnosis, or depending on the wording. Yeah, if it's confirmed, so if it's provided as a diagnosis, then of course it's a confirmed one.
And just on the previous example, at what instance do we code the LLT abnormal renal abnormal conclusively than splitting and code each?
You would only assign these more general terms when you get a verbatim that clearly states, well, some of the lab values for renal function were abnormal. Then you would select one of these terms, more general terms.
Thanks, Caroline. And can we code two different LLTs with a similar PT?
With the same PT, it doesn't make sense because you would duplicate the event. So this would be one of the examples that we had before, where you would then assign the LLT name or the name of the PT, the LLT that is exactly the same as the PT name. So we had this with a pain in extremity before. But if
just one,
the LLTs are linked to different PTs, then of course you would split code.
Thanks, Caroline. And we just have one clarification on the sepsis example. Mm-hmm. The main diagnosis is sepsis. Why are we not coding sepsi?
We are coding sepsis. We are either coding septic shock or we are coding sepsis and septic shock. So okay. Of course you have to capture the information that the patient suffered a sepsis. You would just not only code the shock.
Thanks, Caroline. That's all the questions I think at this time. Thank you.
Yep. Welcome. So let's go. Yeah, we have an hour left, so and I'm on slide number 56, and we have many more, so I will have to speed up a bit. So here comes the next advanced coding principle, combination terms. The first example on the slide refers to such a term, but not to a diagnosis with signs and symptoms, as we saw earlier, but to terms that relate to the same overarching medical concept, but where one is more specific than the other. So the slide shows two examples from the points to consider document. Arrhythmia due to atrial fibrillation. Atrial fibrillation is more specific. It's a more specific type of arrhythmia. So we would code this verbatim to atrial fibrillation. Hepatic function disorder specified as acute hepatitis. We code to the specific type of hepatic function disorder, the acute hepatitis. So these are exceptions. So this is maybe related to the question that we had earlier. So these are examples where you would not split code because of medical considerations. Here, the arrhythmia is specified as atrial fibrillation, so we would code atrial fibrillation, and the hepatic function disorder is further specified as acute hepatitis. So you would not split code in these instances. But sometimes you'll see MedDRA combination terms as well, which relate to two separate medical concepts. For instance, combining a defined medical condition with its etiology or additional attributes. Remember our previous example with the sepsis and the shock, where we found a combination term that was septic shock. And here we have additional examples. Retinopathy due to diabetes can be coded to diabetic retinopathy. No, you don't have to split code here. Rash with itching to itchy rash, or breast cancer HER2 positive can be coded to HER2 positive breast cancer. So HER2 stands for human epidermal growth factor receptor 2, and its overexpression promotes the growth of cancer cells, meaning that its presence has really a significant impact on treatment decisions and the prognosis of the patients. So this needs to be captured, and we have a perfect combination term for it. If you get a verbatim representing combination of relevant clinical information and no corresponding combination term is available in MedDRA, then you should split code. You should select more than one LLT to capture the full information, all relevant medical information. In the first example, we should split code to two LLTs, diarrhea and vomiting. Diarrhea and vomiting are two separate PTs in MedDRA. Wrist fracture due to fall. Again, capture all information. The fall may have been caused by the drug because it made the patient feel dizzy. So you have to capture all information to be able to search for it in your database, to be able to look for patterns and safety signals. Then we have a reported BRAF positive malignant melanoma. Again, split this information to capture both the specific malignancy and the gene mutation. So here we don't have a combination term. Here we would need to split code. Next example for you. Here, a retinal disease from HIV with near total blindness, right and left eye, is reported. So how to capture all this information? Can we assign one code only? Do we have to split code? And how would we split code? Retinal disorder, HIV disease, blindness, HIV retinopathy, and or blindness, both eyes. Again, split of opinions here. Most of you are going for HIV retinopathy and blindness, both eyes. Let me close the poll. So let's first look at the retinal problem. We have a reported retinal and HIV disease and could split and select retinal disorder and HIV disease. But HIV retinopathy is a perfect combination term for this retinal disease from HIV. So MedDRA contains really quite a number of such combination terms. Look out for them and use them. Now, do we have to consider additional information in our verbatim for coding purposes? So we have to, because the subsequent complication, the blindness of both eyes, needs to be captured as well. It's not a characteristic sign and symptom of the retinal disease from HIV, but it's to be considered a sequela, so a late complication. So it cannot be subsumed under HIV retinopathy, but needs to be captured separately. And the most specific term that we have is blindness, both eyes. So well done, most of you. Here we are. If there are questions, just interrupt me, Leander. Otherwise, I will continue.
Thanks, Caroline. There are some questions, but I think if you carry on for a moment.
Yeah. So the next advanced coding topic are medication errors. A medication error is any unintentional and preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of the healthcare professional, patient, or consumer. So meaning physicians, pharmacists, nurses, patients, consumers, or their families. The second aspect that is highlighted in green is important to remember. These errors occur during product use in the medication use process, when the product is under the control of healthcare provider, patient, or consumer. The term does not refer to errors that occur during manufacturing or are caused by wholesalers, in other words, outside of the control of the healthcare provider, patient, or consumer. Important to remember. If a medication error is reported with clinical consequences, like in the first example, patient was administered wrong drug and experienced hypotension, both the medication error and the consequence of the error needs to be captured. So the closest matches are LLT wrong drug administered and LLT hypotension. In the second example, it is reported that because of similar sounding drug names, the wrong drug was dispensed. As a result, the patient took the wrong drug and experienced a rash. So we have 4 interrelated events. First, the wrong drug was dispensed. And the report also states the contributing factor, that the 2 drug names sounded alike. The consequent error is the administration of the wrong drug. leading to a rash in the patient. It is a chain of events and all reported events have to be captured. And in the third example, it is reported that insulin was given using the wrong syringe. Here we have 3 interrelated events. The insulin given in the wrong syringe is the first thing that happened. It resulted in an administration of an overdose, and then the patient developed hypoglycemia. So we would code to drug administered on wrong device. Because this was not an intentional action here, we would consider this an accidental overdose, and it led to a hypoglycemia. So all of these events have to be captured. So here we are. If a medication error is reported and it is made clear that there were no clinical consequences, the PTC guidance provides us with 2 coding options. When it is reported that an intramuscular formulation medication was given intravenously instead of intramuscularly, but the patient did not experience any adverse effects, the preferred option is to code intramuscular formulation administered by other route only. The alternative option is to code no adverse effect in addition. Again, you are free to choose either option, but document your rules and ensure that they are applied consistently. Sometimes also potential medication errors are reported. Such incidents should also be captured as specifically as possible. Also, the contributing factors should be captured, like in this example from the PTC document, where it is reported that the pharmacist notices that the names of 2 drugs look similar and is concerned that this may result in someone getting the wrong drug. So you would code drug name lookalike as the contributing factor to a potential error, and you could code this potential error to a very specific LLT, potential for medication error, wrong drug. Why do some regulators want to receive this information, are actually very keen to receive such information? Well, because in such scenarios, no medication error happened yet, but could, of course, occur in the near future based on the reported contributing factor. When understanding the background for these potential errors, regulators can take steps to prevent errors even before happening. So depending on your local requirements, do not omit such information, but capture all relevant information when receiving similar verbatims and code both the potential for an error by selecting one of these PTs and also code the contributing factor or factors. Although not being an adverse event, such incidents may need to be included in periodic safety reports as well, depending on your regulatory requirements. So to better understand these concepts, please refer to the Points to Consider document for MedDRA term selection, because you'll find very useful information in there that will help you understanding how to use these terms. Also, I would like to make you aware of one additional Points to Consider document, the so-called MedDRA Points to Consider companion document. This document provides even more detailed guidance specifically around medication errors and more examples to help you to distinguish the different concepts. And another tip, the best approach for finding suitable terms is the top-down navigation in the browser in HLGT, medication errors, and other product use errors and issues. So let me see whether I can switch screens now without complications. No, it works again. I don't know how this. So let me show you. So you would need to do a top-down search in SOC injury. Here you have the medication errors and other product use errors and issue, HLGT, and you see here the HLTs. They are grouped based on the stage where the error occurred or issue occurred: administration, confusion, dispensing, monitoring, preparation, prescribing, selection, storage, transcribing. So here you would find the relevant terms, and they are very granular. If you open the administration errors and issues, you see all these PTs. So if you're not familiar with those, with these terms, we had the dose and dosage before. So it's really relevant to distinguish these different concepts, and therefore it's really useful to refer to the MedDRA concept descriptions. So now let me show you where to find the related documents, how to use on the MedDRA website support documentation. Just click on it, and here's the page. The points to consider documents in MedDRA best practices document is on top. And here you have the MedDRA term selection points to consider document in different formats. And here you have the companion document, the latest version of the companion document. And if you click on it, you will see that it really contains a lot of information about the medication errors. Here it is. It starts at page 13 up to page 23. You have lots of information, explanations, and examples related to medication errors. So here the specific examples here down, and so you see it's a lot of examples that you have here for the different scenarios. So if you are interested in this area, look into this companion document, and also we have a separate webinar for coding medication errors, just to let you know. So if this is important for your work, it's useful to join this webinar. So here we have this webinar, general principles. We also have a self-learning system, the learning management system, and a specific module that contains a lot of information about medication errors. And we have also a MedDRA YouTube channel. So if you cannot join one of these webinars, then you can watch recorded sessions of the medication errors webinar on the YouTube channel. And I will show you where to find it later on. Okay, now let's address a more specific topic that may also relate to medication errors: overdose, toxicity, and poisoning. If overdose, poisoning, or toxicity is reported, extract this information and code accordingly. Poisoning by drugs and drug toxicity are considered synonyms in MedDRA. You will find the relevant terms under PT toxicity to various agents. You may ask yourself when to consider a high dose as overdose. Well, you saw the concept description in the browser I've shown you before. It says, for the purposes of term selection and analysis of MedDRA coded data, overdose is more than the maximum recommended dose in quantity and or concentration. In other words, an excessive dose. And if an overdose is reported with clinical consequences, you would code both the overdose and the resulting events. If there are no clinical consequences, again, you have two options. The preferred option provided in the PTC document asks to quote the overdose only, but you also have the option to select the alternate option and code overdose and no adverse effect. So again, document your rules in your coding conventions and apply them consistently. Another advanced principle addressed in the points to consider document is death and other patient outcomes. Death, disability, and hospitalization represent patient outcomes and seriousness criteria as well, and are normally not captured as adverse events or adverse reactions. But if one of these outcomes is the only information that is received, then you would code as specifically as possible. And also, if a death term would add relevant medical information, you would code it in addition. Here an example. Patient experienced a rash and had sudden cardiac death. So if you would ignore the information sudden cardiac death in this instance and not capture it, you would of course omit relevant clinical information, because it can be considered unusual that a rash leads to a sudden cardiac death unless the patient had additional medical problems already. So that's why you always have to apply medical knowledge in order to decide whether split coding is necessary, yes or no. Suicide and self-harm is another special topic addressed in the PTC guidance. When coding suicide attempts, completed suicides, and self-harm, clearly distinguish these scenarios. Be as accurate as possible and handle these terms consistently. Do not assume that an overdose, even if it is reported that it was intentional, relates to a suicide attempt. Same holds true for reports on self-injuries. If a suicide attempt or suicide are not mentioned in the report, only code the intentional overdose or the self-injury. Remember the basic coding principle. Do not interpret what has been reported by adding information. Code as reported. And if a suicide attempt has a fatal outcome, make sure to capture it as completed suicide. The outcome makes a big difference here and needs to be considered when coding, because it's two separate PTs. Suicide attempt is one PT, completed suicide is another one. So, and this was actually what an inspector checked in a drug safety database of a pharmaceutical company. He asked for all cases that were coded to suicide attempt, but with a fatal outcome, in order to assess the quality of data entry and coding in this database. Based on what you just heard, which of these LLTs would one select for a reported death from cerebral hemorrhage? The verbatim specifies an event, a medical event with its outcome. So options would be sudden death, death, cerebral hemorrhage, brain death. It's death from cerebral hemorrhage. And as just discussed, in such cases, we do not need to code the death of the patient because it is an outcome and captured in a separate database field as a seriousness criterion. In our case, the reason for death is reported, and this is what we would capture. And LLT brain death means something different. It means that the brain has lost its function, but the patient must not be dead, but maybe comatose and depend on life-sustaining measures. So the correct code assignment would be cerebral hemorrhage in this instance. But if the outcome death is the only information in a case, then of course an appropriate LLT for the reported circumstances of the death of the patient must be captured. For the reported outcome, patient was found dead. Found dead would be the most suitable term assignment, as it is closest to what has been reported. I'm rushing now a bit, Leander. Any relevant questions?
We had a question on the near total blindness question.
Yeah.
So near total blindness will be considered as complete blindness or vision impairment.
What was exactly the, I didn't get it. Neonatal blindness?
No, near total.
Near blind. No, difficult question. Yeah. Usually in drug safety, you would take, this is at least what we did in my previous company, take a worst case approach and consider it as blindness. But it really depends on some more case information. If there's no more information in the case, near blindness, I would take the worst case approach. But again, that's a company decision how to handle those. And it may be even product specific decisions.
Thanks, Caroline. And is it safe to say in investigation, one uses the terms such as increased, decreased, abnormal, only while for events that are repeated independently of being investigated and have to be coded the event as more directly?
So if it's reported, if an investigational finding is reported at an adverse event and not in the lab value in a CRF, for instance, but if a lab value is reported as adverse event, you would code as reported. So if it's increased, you would code it specifically. If it's decreased, if it's vaguely reported, you only know something was not normal, then you would select the abnormal term. So it really depends on the type of report.
Thanks, Caroline. And in the aldosterone example, could you explain once again why we should choose aldosteronism in the previous case?
Yeah, because it's really features of aldosterone excess that the patient suffers. So the patient had signs and symptoms of aldosterone excess. It was not just a lab value. It was that the patient really suffered from aldosterone excess. And that's why you would go to aldosteronism, because it's a condition in the patient that was reported there. It was not just an aldosterone value that was reported.
Thank you. And could you provide a bit more insight as to the reason why we would code arterial fibrillation and not arrhythmia?
Yeah, because if you have two events that relate to each other, so it is said the patient suffered an arrhythmia and then it's specified as atrial fibrillation, then it would be sufficient to code the atrial fibrillation, because this is the most specific information about the arrhythmia that you have. And same holds true for the other example with a hepatic disorder or hepatic function disorder that is then specified as a hepatitis.
Thanks, Caroline. I think that's good for questions for the moment. I'll check to see if there's any more.
Okay, so the drug interactions is another example that is important to remember. The term drug interaction covers interaction between drugs, including biological products, but also between drugs and foods, devices, alcohol, etc., etc. If an interaction is reported, then capture the interaction and the subsequent medical events. And you see an example here. It is clearly stated by the reporter that an interaction occurred, and we should capture this information. So make sure to code this interaction as specifically as possible. Here, it is a food interaction, but you may also receive reports of drug-drug interactions, drug-alcohol interactions, device interactions, drug-device interactions, drug-disease interactions, etc., etc. So MedDRA contains plenty of terms for such interactions, very specific ones. But what if a reporter does not specifically state that an interaction occurred, but only mentions that 2 or more drugs were taken together and reports a medical event afterwards? So in such instances, you should not assume an interaction just because the patient is taking several drugs, but select terms for the reported medical events only. So another question for you. After taking an antihistamine along with her prescribed proton pump inhibitor, a woman developed vertigo. How would you approach it based on what you just heard? Would you call drug interaction, NOS, vertigo subjective, vertigo, and or drug interaction? Vertigo, correct. That's the condition, but you would go for drug interaction. I just mentioned, let me close it, that we should only assign a drug interaction when it's explicitly reported. Here, the only thing that we know is that the patient was taking 2 drugs. So antihistamine and a proton pump inhibitor. That's only, and then she developed vertigo, but it's not stated in the report that this relates to a drug interaction. She could have developed vertigo due to other reasons, ear problems whatsoever, not due to a drug interaction. So that's why we would code this to vertigo only. Always remember that we only code to a drug interaction or any type of interaction when explicitly reported. Any questions? And otherwise, we start with our coding exercises now. Quite late, but it's always good to answer questions, because otherwise you get lost with all the information that you get during our webinars. So I will try to cover as much coding exercises as we can.
Yeah, absolutely, Caroline. You're right. We do get feedback that says people like to answer the questions as we go along. So
Yeah.
I know we have to adapt to the time. We did have a question that said, so LLTs and PTs can be the same.
Yes, there's always an LLT that has exactly the same name as the PT. That's a fundamental MedDRA rule. So for the PT, yeah.
No, that's great, thank you. And I think this one is too specific, but you'll guide me on this. What coding should be applied if a patient reports a quality defect in a product? For example, they claim there were lumps in a cream which caused facial irritation and burning, but the alleged quality defect has not been confirmed. Is that too specific?
It's quite specific, yes. It depends on the case and the information that you have. Usually, if you just get this information, you would code the quality defect, and we have very specific terms for it. This is a physical finding in the medicinal product, medicinal product plus the event in the patient.
Thank you. And if we had separate terms referring to signs and symptoms, we would have to code separately, but we can assume for the medical review a possible diagnosis. Is that correct?
Yeah, so as a coder, you code as reported. Deriving a diagnosis from reported signs and symptoms or lab values whatsoever is another task. This is in the hands of the product experts, of the medics that are doing the data retrieval and the data analysis. So they are looking at the signals, at aggregated data, and they then make conclusions based on medical considerations. But this is not the task of coders. So we code as reported based on the rules that are outlined in the MedDRA term selection points to consider document. So don't interpret anything. Don't interpret, don't add, don't interpret, don't subtract, code as reported. Really, that's the basic MedDRA rule.
And again, I'm not sure if this is too specific. You'll guide me. Should a medication error occur and it affects a patient who already has an existing condition, for example, they are in ICU, when coding, do we need to include the condition as well?
It really depends on the case. It's very specific. So more information would be needed. So if there's a medication error, you need to code it. Yeah. You have to code everything, the medication error, the conditions in the patient, the findings whatsoever.
Thanks, Caroline. And I'm just seeking clarification on another question, but I think if we go to the exercises, and I'll put the credentials, the temporary credentials now in the chat.
Yeah. The last question. So causality is not to be considered when doing coding. You code as reported. So when it's reported that a medication error occurred, and you would code the medication error and all the conditions, because it's irrelevant for coding to whether this has a causal relationship to the medication error, yes or no. A medication error occurred, so code it. So before, and we saw that with many of the examples that we saw earlier, before trying to code something, always look at the verbatim first. What is reported in the verbatim? Is it a clinical condition, an indication for use, a test result? Is it a product quality issue whatsoever? Because, or is it a combination term? Is there a combination term available in MedDRA? Because the type of reported term will influence where you would look in the browser to find the closest LLT or LLTs that best match your verbatim. If it is a medication error, you would look into the injury SOC. If it is a product quality issue, you would search in the product issue SOC, etc., etc. So now let's start with our exercises. Leander has already put the credentials in the browser. So if you would like to use the legacy browser, here is the link to the legacy browser, and you also find it here on the website. Here's the shortcut to the legacy web-based browser, and here's the password that you can use. It's only a temporary demonstration password, so it will expire in a few days from now, but you can use it for now. This is the link to the new browser, and you find it when you open how to use tools, and then you can just click on this link, open the new web-based browser, and you will have access to the web-based browser again with the same credentials. Username 70001, and here the password. And Leanne has put it into the chat as well. And just if you have lost connection to our polls, here's again the QR code. And let's start. Became colorblind in adolescence. How would you code this term? Color blindness, blindness color, color blindness acquired, or color blindness acquired in American English? What would you do? So let's see. So most of you are going for color blindness acquired, and that's completely correct. Here we are. So let me switch to the browser, hoping that it will work. Oh no, not this one. Here we are, web-based browser, log in. If I enter color blindness, as it was reported in American English, you see there's word order differences. MedDRA is very granular on LLT level. And we have blindness color total. You see it's grouped under color blindness. And we have the acquired condition, color blindness acquired. So let's see what the difference is. If I click on color blindness, right mouse click, go to browser, you see that color blindness is grouped under congenital. We know that this condition was acquired by the patient. It was not a congenital condition. So again, it's important to check the hierarchy of the respective terms in order to make sure that you are on the right path here. So selecting color blindness only would not be correct, because you would end up in a congenital SOC. And what has been reported is an acquired condition. So let's do the same with color blindness acquired. Go to browser. And here we are in SOC eye disorders. And here we have the acquired, color blindness acquired. Here we are. So that would be the correct code assignment for our verbatim. So check the hierarchy. because color blindness is mostly congenital. That's why it's grouped under congenital. But we know that it was acquired in our patients. So that's why we have to capture this information. It's relevant. Here we are. Color blindness acquired. So we would always try to follow the American or British English spelling, but of course it's not as relevant. The medical concept is most relevant, so you have to capture the fact that this color blindness was acquired. Next one. Turned very greasy. What is reported here? Is it a disorder in the patient? Would be coded to ill-defined disorder, or skin greasy? Is it an unavailable event, or is it an unavailable reaction in the patient? Turned very greasy. What could this relate to? Do we know what turned greasy? Unavailable event is what most of you are selecting, and that's again correct, because here we are. We don't know. Is it a condition in the patient? Could be the skin, or it could be the hair. But it may also relate to a medicinal product like an ointment, which has become very greasy. So that is why I wouldn't go for ill-defined disorder in this instance, and I wouldn't make the assumption that the skin of the patient turned greasy. We also don't know whether this was a product quality finding, and LLT unavailable reaction would not fit either. We do not know whether the verbatim describes a reaction to a medicinal product in the patient. So the best LLT to select here is LLT unavailable event, and most of you have taken this approach. So well done. Here we are, unavailable event, because we don't know whether this is relates to a product quality issue or whether this is a condition in the patient. Next one. Similar. Patient experienced a medical problem. So this is quite clear. What would you do with this one? Adverse event, unavailable event, unavailable reaction, or ill-defined disorder? Remember what we discussed earlier when talking about vaguely reported conditions. So obviously this patient had a medical problem, so it's referring to a medical condition in the patient that is not specified. Exactly, ill-defined disorder would be the correct assignment here, because it's a condition in the patient that is reported here, but this condition is not specified, and that's why we would say ill-defined disorder. Coding to adverse event would imply that the patient was exposed to a medicinal product or a study drug. So this verbatim could relate to the medical history of the patient, yeah, or could be an event in a follow-up period with no drug exposure. We don't know. And the reaction term would even imply causality to a drug or medicinal product. So ill-defined disorder would be the correct code assignment here. Here we are. Next one. The patient reported a loss of smell and thought that she might have a COVID-19 infection. So we have a sign and symptom and a suspect diagnosis here. The patient thought that she might have a COVID-19 infection. Would you assign anosmia, suspected COVID-19, loss of smell, or just COVID and/or COVID-19? What would you do? Exactly. So code is reported. We have an LLT for suspected COVID-19. We have an LLT for loss of smell. Anosmia would be the medical term for loss of smell, but we would always try to be as close to the wording of the term as possible. It's not incorrect, anosmia, but we would stick to what has been reported, and that is loss of smell. So it's a direct match in MedDRA. Here we are. Well done. These are the correct code assignments. We have, it's a suspect diagnosis, meaning that based on the preferred option, we would have to code both the suspect diagnosis plus the related sign and symptom. And here we have the loss of smell and the suspected COVID-19 infection. Any questions so far, Leander?
No, we're fine at the moment, Caroline. If you carry on, thank you.
He was given drug Y to treat a BRAF gene mutation related colorectal cancer. BRAF. So we have a BRAF gene mutation and a colorectal cancer. So very specific information about the type of colorectal cancer here. How would you code this one? Colorectal cancer, acquired gene mutation, BRAF gene mutation, or colorectal carcinoma? Exactly. You would be always as close to the verbatim as possible. Colorectal cancer is a direct match in MedDRA, and the BRAF gene mutation as well. Acquired gene mutation would be too unspecific. It's more vague. The BRAF gene mutation is much more specific. Colorectal carcinoma would not be incorrect, because you heard that carcinoma and cancer are considered synonyms in MedDRA, but you would always try to be as close to the verbatim, the wording in the verbatim, as possible. So that's why colorectal cancer and BRAF gene mutation would be the correct code assignments here. Here we are. Next one. Infection after surgery. Would you just code it to infection, or post-operative wound infection, or surgical wound infection, or post-operative infection? So if you would enter infection into the browser, you would get hundreds of potential hits for your search. You'll have to make your search more specific by adding the word stem search, or for surgery, or surgical, or a synonym like opera. So a word string for operation or operative. Or you could also restrict your search to surgical and medical procedures, or injury. So what are you? Post-operative infection, exactly. This was an easy one. So there's quite a number of terms that relate to post-operative conditions in MedDRA. So if you have such a term, always look for post-operative or post-procedural or after surgery terms in MedDRA. Always worthwhile to look for them. Here we are. Very specific LLT that can be assigned to this verbatim, post-operative infection.
Helen, we had a query on the COVID-19 one, if you don't mind taking that. Why can't we only code the suspected COVID-19 rather than both the loss and smell and suspected COVID-19?
Well, we said, based on the rules that I've shown before, that the preferred option for coding a suspect diagnosis that is reported with signs and symptoms is to code both the suspect diagnosis and the sign and symptom. That's what we said before, and we always follow the preferred option in our trainings. Of course, you can take a different approach. You can take the alternative approach and just only code the sign and symptom, but we take the preferred one, and this means code the suspect diagnosis and the loss of smell. And because we have a term for suspect COVID-19, you would of course capture as much information as you can when coding, always.
Thanks, Caroline. And why is it suspected COVID-19 if it says she has COVID-19? Oh, because she might.
It was not confirmed yet by lab values. So she just had a loss of smell. Maybe she had a contact with a COVID-19 infected person. So she was suspecting that she could have COVID-19 because this was a typical symptom of a COVID-19 infection. So, but it was not yet confirmed.
Thanks, Caroline. I think that's it for the moment, but I'll keep checking. Thank you.
So, okay, let me switch back to the next. Here's the next one. She was abused by her husband. That's what is reported. Is this a physical abuse, spousal abuse? Is it describing a battered wife, or is it a victim of spousal abuse? What is reported here? Always look at the verbatim, try to understand what is reported here. Victim of spousal abuse. That's, most of you are going for this one. Others vote for spousal abuse. I said, well, it's not specified what type of abuse there is. So physical abuse or battered wife would be incorrect. But what is it a spousal abuse or is it a victim of spousal abuse we are looking at? So let me close the poll here and let me switch to the browser. Same problem again. This is unbelievable. Unbelievable. So let me close my presentation. Here we are. And just take the browser. So here now we have to go to social circumstances, SOC. Last week I told you that this is something, a special system organ class, social circumstances. Or let me just look for spouse and abuse. Spouse abuse. Here we are. So it's always good if you don't find anything, don't spell out the full name, but just take a few, part of the name or of the wording of the verbatim in order to find a term. Here we have spousal abuse, spousal abuser, and victim of spousal abuse. Now let's go to browser again, social circumstances, and you see that under HLGT legal issues, there is an HLT for criminal activities. So this is the abuser perspective, so to say. So, and here we have the spousal abuse, spousal abuser. But what was reported in our case was a victim of spousal abuse. So let's go for this one again, go to browser. And we are again under the same HLGT, legal issues. But here now we are in HLT crime victims. And you see the victim of spousal abuse. Here it is. There may be also sexual abuse, child abuse, victim of chemical submission. So victim of spousal abuse, the abuse type was not specified. So this would be the best approach that we can take here. Now let me go back to my slides. And we need to be on page. Here we are, 107. Here we are. That would be the correct code assignment, victim of spousal abuse. Next one. A 27-year-old woman took a 2-week course of antibiotics during her pregnancy. She did not experience any side effects. What would you do with this one? maternal exposure during pregnancy, no adverse effect, or normal pregnancy? What would you assign here? Again, think about the preferred approach. Maternal exposure during pregnancy, of course. We don't know at which time point this occurred. It was during her pregnancy, whether it was in the first trimester or second or third. So that's the most specific term that we can find. And we were told that no adverse effect happened. Correct. Here's a screenshot of the related guidance in the Points to Consider document again. In the same chapter, you also find explanation on how to handle coding of events in the child or fetus due to drug exposure of the mother or father. You see again that we would, of course, capture the maternal exposure during pregnancy, that the preferred option, and if no adverse effect occurred, you can capture it, but it's the alternative option. So usually you would just only code the maternal exposure during pregnancy. So here we are when taking the preferred approach. And just to show you what type of terms are available in MedDRA for such cases, exposure during pregnancy. So we have 3 of them at first. The first and the third one, drug exposure before pregnancy, exposure during pregnancy, can be used when it is not clear who was exposed during pregnancy, father or mother or fetus. And the second one refers to fetal exposure, exposed to maternal infection in utero. The next group here, these are terms that can be used when fetal exposure is reported or suspected by a reporter, via breast milk, during delivery, during pregnancy, timing unspecified, or via father. The next group can be used when maternal exposure is reported and or suspected by the reporter, before pregnancy, during breastfeeding, during delivery, during pregnancy, timing unspecified, or via partner. And the last 3, these are the PTs that you can use when an exposure of the father is reported or suspected by a reporter. So important to really distinguish these PTs. So I think we should, I should now, we're getting to the end now. Let me switch to, we didn't cover all of them, but I really prefer to handle all the questions and take time to go through all these examples and not rush through them, because I think that nobody has really a benefit of it. So please excuse if we didn't capture or cover all the examples that I had prepared, but as I said, I prefer to really stop and take the questions, explain, so that everybody can follow what we are talking about. So let us now, a short summary of our MedDRA coding pearls. So first of all, you can not only use MedDRA for adverse event coding, but of course you can code indications for use. You see a narrative here. Those of you who are working in pharmacovigilance are familiar with this type of report. So you have a indication for use that you can code: rheumatoid arthritis. You have medical history data, colon cancer, cigarette smoking. You have the actual adverse event, aortic valve stenosis. Then the patient undergoes a surgery, aortic valve replacement, and suffers a sternal wound infection afterwards, after the surgery. All of this can be captured with MedDRA. Now, some valuable tips at the end. Whenever you are searching for a suitable term for a verbatim or for terms from a narrative like we saw before, first try using the actual words of the reporter. You better use word stems, like for example, pancreas, to cover both pancreas and pancreatic for your search, because if you are too specific in your search, as I was when entering spousal, I had to use a word stem in order to find a suitable term. If you're too specific, you may not find any results, and you should use singular terms, not plural terms, and replace words with synonyms if you don't find a suitable hit in MedDRA. Like, for example, replace intentional by deliberate or unintentional by accidental when coding medication errors, so errors in medicinal product use. If you have found a somewhat suitable term, be aware of MedDRA specificity, granularity, and always look for LLTs under the same PT that may even better capture the verbatim, and also look for the sibling PTs in the same grouping under the same HLT, because there may be PTs that are even better matches to your verbatim that include additional information like, for example, demographics, acute or chronic, post-procedural occurrence, etc. Remember we didn't so if you have a drug exposure, accidental drug exposure of a certain patient is reported, and it is a drug exposure by a child, then you will find very specific terms in MedDRA for child exposure, for exposure of elderly patients, or just exposure by a patient. So MedDRA is really very granular. Always explore the hierarchy for the best match for the reported condition. And you have found, if you have found a suitable term, always check the hierarchy, where the term lies in MedDRA, in order to reassure yourself that the hierarchy represents your reported condition correctly. Remember our example with the acquired color blindness. If we had chosen just color blindness, it would have been in the congenital SOC, and that hierarchy would be wrong for our coding scenario because the verbatim was referring to an acquired condition. When searching for suitable terms, use the top-down and bottom-up navigation. If you have difficult verbatims, use available resources for clarification, among those also the concept descriptions that you can find in the MedDRA browser. I've shown you where to find them. And use the advanced search function or restrict your search to a SOC to narrow down your searches when needed. For example, when you get a long list of potential hits in your browser. And of course, you should get more coding training and of course coding practice via a high coding turnover. The more that you code, the more experience, the more professional you will get, the more accurate and consistent your coding output will be. So this is what we have covered today. Now it's the last chance for questions. Any further questions, Leander?
We've got a couple of questions. I'm also conscious of time and people needing to leave. But with the abuse example, should this should social circumstances be coded as a medical condition?
Well, usually you would not use social circumstances terms as an adverse event, only in exceptional cases, and this would be one of the exceptional cases. So if a patient is taking a drug and has an admission to hospital because of spousal abuse, she's a victim of spousal abuse, then you wouldn't have to code it somewhere. Then it's of course a social circumstance, but it's the most specific term that you can assign. Usually you would not use social circumstances terms for adverse event coding, just in exceptional cases.
Thanks, Caroline. And when a post-operative event is reported, but MedDRA does not have such terms with post-operative description, should we code both the event reported and the post-operative complication? Yeah,
that's always a good question, really good question that it's really difficult to handle because there is no specific guidance in the PTC document in this regard. So you can take either the option to only code the condition, or you could split code and code the condition plus the information that this was a post-procedural complication. But after all, you have to consider, well, it's not that this was caused by the procedure. It's the post-procedural terms do not convey any information about a causal relationship between the procedure and the actual event. So it's questionable whether this needs to be captured. But if for product-specific considerations whatsoever, this information is relevant, you would rather split code.
Thanks, Caroline. And if the patient says, I may have cancer, do we code suspected cancer?
I may have cancer. Oh, difficult question. It depends on the case information that you have. So if there's reported signs and symptoms that really underline this suspicion of the patient, you would do so, but you would rather also try to get further information in order to see whether there are subsequent investigations that confirm this suspect diagnosis by the patient. Difficult question, and really it's very specific.
Thanks, Caroline, and that's all for now. Thank you.
Okay, so these are some useful links to additional information, our website, the help desk email, our website frequently asked questions part, where you may also find answers to your questions. Again, the links to the browsers, to the change request tool that we have in order to submit change requests to MedDRA, the training schedule. So if you're interested in other webinars, you find the schedule there, and the MedDRA support documentation. Again, the link I've shown you how to find the support documentation on the website, on the MedDRA website. These are the coming webinars you may be interested in. So if you did not yet attend the MedDRA Coding Basics, so this was yesterday, so not any more relevant, but you see that we also have webinars in different languages like Spanish, Korean, Chinese, French, so you can attend these webinars. This is continuously updated at the end of each month. So this is just what you see today, and during next week, new webinars will be posted for November, maybe even December. For more advanced coders, we have the Let's Code webinars, more in a workshop format, where we distribute the verbatims that we will address during the webinar beforehand, 1 week before the actual webinar takes place, so that the attendees can prepare themselves and can discuss the verbatims. You see that the one that will be provided next week by my colleague Jane and myself is already booked, but there's another one in US Eastern Daylight Time Zone on 22nd of October, and in December Jane and I will also provide another one. Let's Code Together. And this is the MedDRA Coding of Medication Errors General Principles webinar I've been talking about. If you are interested in this topic, here on the 9th of October in US Eastern Time we have one, and I will provide another one, medication error webinar, beginning of November as well. So it will be posted soon. And we have our LMS system. I mentioned our self-learning system already. So self-learning videos guides you through a predefined learning path. There's beginner and advanced levels, certificate and non-certificate tracks, and there's an unlimited number of accounts per organization. It was launched beginning of this year, and this is how you can access it, either by this QR code or by entering this web address here. And these are some of the topics: overview of MedDRA coding and analysis, then some specific coding topics like the ones that we have discussed today, outcomes, suicide, social circumstances, pregnancy, medication errors, and also interactive MedDRA coding exercises where you get immediate feedback for what you have entered into the tool. And last but not least, I would like to show, I mentioned our YouTube channel, and this may be relevant for you. So now let me switch screens again. Here we have our MedDRA website. If you click on contact here, this page will open, and here is the YouTube icon. And if you click on it, here you will find all the recorded sessions of the different trainers of the MSSO and the different languages. So you see Brazilian Portuguese, Arabic, you see Spanish, Chinese, Russian, where is our colleague, French here, Korean, so many in English, of course, and the different trainers. And you can just click on it and see, for instance, the Let's Code Together in Chinese, or where is here is Jane and myself with our Let's Code Together. You see, we started in 2020 already. So lots of these sessions are recorded, and you can watch them if you are interested in it. So this was all. Sorry for the problems that we had again with technical problems. Sorry for that. But we managed. And with this, I would like to thank you for your interest in today's topic and for your active participation. I hope you found this webinar useful and hope to meet you again in one of the trainings that we offer on a regular basis. And also a big thank you to you, Leander, for your support today. We had many questions. So enjoy the rest of your day, and goodbye for now. Bye-bye. Thank you.
Thanks, everyone. Really enjoyed
Bye-bye.
it. Thanks, everyone. Thanks, Caroline. Bye-bye, everyone.